to the segment 2, health assessment, head to toe, which is the neck and the thorax-respiratory. So now, we will assess the neck beginning with inspection. So, sir, I would like to lower your down, sir.
The patient's neck should hold his head erect and midline. It should have symmetrical muscles and no swelling or masses. If you see swelling below the jaw angle, palpate this area to check for a parotid gland problem. Assess the neck's active range of motion by having the patient touch his chin to his chest, turn his head to the right and left, tip his head toward his right shoulder and toward his left shoulder, and tilt his head backward. All of these movements should be smooth and painless. Next, assess the spinal accessory nerve. Apply resistance to the patient's shoulders. As he shrugs, limp the shoulder muscles should be symmetrical and able to overcome your resistance. Now, have the patient turn his head to one side as you apply resistance to the side of his chin. Then have him turn his head to the other side as you apply resistance to the opposite side of the chin. Note the contraction of the opposite sternomastoid muscle and the force of the movement against your hand. Movement should be equal strong. Next, move on the lymph nodes in the neck. With the finger pads of both hands, bilaterally palpate the nodes using a circular motion. Palpate the lymph nodes in this sequence: pre-auricular, posterior auricular, occipital, submental, submandibular, tonsillar, superficial cervical, deep cervical chain, posterior cervical, and supraclavicular. Note the size, shape, consistency, mobility, and tenderness of the nose. Be sure to compare one side to the other. Normally, the lymph nodes are small, soft, non-tender, and movable. If you detect swelling or tenderness, search for a possible cause. Now, inspect the jugular veins using tangential lightning with the patient supine his head elevated 30 degrees and turn away from you. Internal jugular vein distension may be visible. Observe the jugular vein pulsation. They should undulate softly and may decrease with inspiration. Note usually prominent pulsation. With the patient sitting up, identify the trachea by locating the sternal notch and sliding your fingers to each side of it. The trachea should be midline and symmetrical. Stand in front of the patient. Use the finger of your left hand to push the thyroid gland to the right. Curve the fingers of your right hand between the trachea and sternocleidomastoid muscle. Then ask the patient to extend his neck and swallows. You should feel the thyroid move up and down as he swallows. Then palpate the thyroid gland from behind. The fingers of both hands on the patient's neck with your index fingers just below the cricoid. Palpate both lobes and isthmus. Instruct the patient to sip and swallow during the exam. Note the size, shape, and consistency of the thyroid. If the thyroid is enlarged, auscultate it for bruits with the bell of your stethoscope. A bruit is a blowing sound caused by turbulent blood flow. Observe the carotid arteries where visible pulsation. Gently palpate the carotid arteries using your index and your middle fingers. Remember to palpate one carotid artery at a time. Otherwise, you could block blood flow to the brain. don't press too hard over the carotid sinus area located higher in the neck, because this could cause vagal stimulation, which could slow the patient's heart rate. Next, the patient take a deep breath and hold it as you listen to the carotid artery. With the bell of your stethoscope, you should not hear a bruit. As the thorax, ask the patient to breathe normally as you observe his respiration. Respiration should be regular and symmetrical, and the accessory muscles should not be used. The patient should breathe comfortable while sitting with his arms at rest. Now, move around slowly to the patient's back. As you do this, assess the anterior, posterior, and the lateral diameters of the thorax. Normally, the lateral diameter is up to twice and anterior posterior diameter for a ratio of about 2. Your finger pad to palpate the spinous processes. They should be evenly spaced and non-tender. Assess respiratory expansion. To do this, place your thumbs at the level of the 10th or the 10th thoracic vertebra. Spread your fingers, allowing for small folds of the skin between your thumbs. Ask the patient to take a deep breath. As he does, watch your thumbs move with respiration. Their movement should be symmetrical. Next, assess for tactile fremitus or voice sounds palpated on the chest wall surface. Using the ball of your hand, feel for vibration as the patient repeats the phrase 99. Move from the apices inside the scapula down to the lower and the lateral thorax in each location. You should feel equal vibration 99. Perform mediate percussion using a systematic pattern so you can compare the two sides. Resonance should be equal over the lungs. You should hear dullness of the diaphragm. Hyper-resonance means you found an area of increased air in the lung or pleural space, as with the pneumonia thorax or acute asthma. Abnormal dullness indicates decreased air in the lungs, as without elect assist or a build-up of pleural fluid. Assess diaphragmatic exertion. To do this, ask the patient to exhale and then hold his breath as he holds his breath. Percuss from the scapula down to where the sound changes from resonance to dullness. Mark this spot with a pen. Next, assess the kidneys using blunt or first percussion over the coast of the vertebral angle. Percussion in this area should not cause tenderness. Tape breath sounds with the diaphragm of your stethoscope. To do this, instruct the patient to breathe deeply through his mouth, starting at the lung apices. Auscultate the lungs move systematically from side to side down the patient's back and lateral toward axilla. Be sure to listen for at least one complete respiration at each location. Normal breath sounds vary with the areas you're assessing. You should hear bronchovascular sounds between the scapulae. These sounds are moderate in pitch and amplitude, with the inspiration phase equal to the expiratory phase. You should hear vascular sounds at the apices down to the bases and laterally. These sounds are low pitch and soft with a longer inspiratory than expiratory phase. Listen for abnormal sounds such as crackles and wheezes, and for coughing, an abnormal respiratory effort. If you hear crackles and wheezes, ask the patient to call, then listen again to determine if the abnormal sounds have cleared. If you suspect an abnormality, have the patient say 99 as you auscultate these areas. 99, 99, 99. Normally, the word sounds muffled and indistinct. Patient's anterior thorax begin with the bones and muscles. Normally, they appear symmetrical and you should not see accessory muscle use retraction or bulges. The patient should not have signs of respiratory difficulty such as cyanosis or nostril flaring. Next, palpate the thorax with your finger pads moving from the long apices to the bases. You should find no nodules or tenderness. Respiratory expansion. Place your hands on the patient's chest along the costal margins with your thumbs pointing toward the sacred process. Have the patient take a few deep breaths. As he does this, watch your thumbs. They should move simultaneously and symmetrically. For tactile firmitude, as the patient repeats the phrase 99, moving from the long apices down to the point below the nipples, comparing size vibration. Next, perform percussion over the lungs using a systematic approach. Start just above the clavicle and percuss in the intercostal spaces down the chest from side to side. Percussion should produce low resonant sounds. Auscultate over the patient's lungs with the diaphragm of the stethoscope in the same pattern you use for percussion. At each location, listen for one complete respiration. Normal breath sounds vary with the area you're assessing. You should hear trachea sounds over the trachea. These are high-pitched, loud, and tubular. You should hear broncho sounds laterally and over the bronchi at the angle of Louis. Inspect to hear vesicular sounds over most of the anterior thorax and the periphery. If you suspect an abnormality, have the patients say 99 several times as you auscultate the areas involved. Normally, the word sounds muffled and indistinct. Thanks for watching.